Okay, final lecture with you, that is antifungal agents. So, just to recall, fungi we can classify as yeast and molds. Yeast, Candida histoplasma, even it's a dimorphic one, Coccidioides and Cryptococcus species, molds, Aspergillus, dermatophytes, mucor. Also, clinically, we can superficial, subcutaneous, and systemic. You can classify them as. So there are a lot of systemic fungal infections you are aware. Systemic candidiasis, cryptococcal meningitis, rhinocerebral mucormycosis, even pneumocystic carinae pneumonia. So fungi, it's a unique cell wall which contain chitin and in a cell membrane there it contains cholesterol. It's mainly ergosterol. So it contains outer manoprotein and there are beta-1,6 and beta-1,3 glucans. Then it can phospholipid bilayer of cell membrane. This is cell wall and chitin also there in the cell wall. So ergosterol is specifically there. So here the one place where beta-1,3 glucan synthesis of. So there's ergosterol pathway. Likewise, it's a eukaryote, but compared to other advanced cells, here it contains chitin and ergosterol. So there are antifungals, which there are leads to inhibition of different states. If cell wall synthesis blocked by azoles and blocked by terbinafine, also blocked by flucytosones, that is about DNA, purine, pyrimidine synthesis, mainly purines. And glycerol affect microtubular functions. And caspofungin inhibits cell wall, and polyins form artificial pores and lead to osmolysis. So antifungal based on the mechanism of action, fungal cell wall thin synthesis inhibitor caspofungin binds cell membrane ergosteroid or such as amphotericin B nystatin. Inhibition of ergosterol plus lanosterol synthesis. Terbinafine, betanafine like. Inhibition of ergosterol synthesis, that is azoles, mainly ketoconazole, itraconazole, isobuconazole like novel drugs. Inhibition of nucleic acid synthesis 5-flucytosine. Disruption of mycotic spindle and inhibition of fungal mitosis, that is glycerol, where we use for dermatophyte infection. There are miscellaneous also. There are, based on the structure, they are antibiotics, polyenes like, and heterocyclic benzofurans like cruciferol. Antimetabolites, it's a flucytosine. It's an antimetabolite. And azoles, imidazoles and triazoles. Allylamines like terbinafine, betanafine, echinocandins, caspofungin, aniludefungin. Other topical agents also there. We'll be discuss about amphotericin B. So obtained from Streptomyces nodosus. So amphotericin in nature often. So lipophilic part is there, lipophilic part and hydrophilic part there. It's amphipathetic. Mechanism of action, as I said earlier, here also amphotericin B interferes hydrophobically with ergosterol in the fungal cell membrane, which leads to formation of a pore. So ultimately, potassium other small molecules are lost to the pore, causing cell death. That's how it occurs. Mechanism again, amphotericin B binds ergosterol in the fungal cell membrane, form force in cell membrane, cell contents leak out, leads to cell death. So antifungal spectrum, it's a broad and fungicidal activity. Aspergillus, blastomyces, Cryptococcus, Candida, Coccidioides, and black fungus muco. Also, it acts on Leishmania as well. Mechanism of resistance. Replacement of ergosterol by other stereocyte fungal plasma membrane. So altered binding site. Resistance is not a problem often clinically. About the pharmacokinetics, it's absorbed poorly oral, insoluble in water. So colloidal suspension prepared with sodium deoxycholate. 90% bound to plasma proteins, metabolized in liver, slowly excreted in urine. T-half is 15 days. Some elimination by part of dose appears in urine over a long period of time. Topical so we can apply, but IV is the one. Minimal penetration into central nervous system, vitreous and amniotic. Administration of we give IV. 50 milligram vial suspended in 10 ml sterile water and diluted with dextrose. So based on the condition we Q. All for life-threatening mycotic infections, invasive aspergillosis, histoplasmosis. Adverse events, acute reactions, infusion-related and drug-related. Acute reactions, once given, chills, fever, headache, those things are there. Usually, dyspnea lasts in 2 to 5 hours because of release of interleukin and TNF alpha. Can be treated with hydrocortisone. Long-term toxicity, nephrotoxicity, that's the one we mainly concern. CNS toxicity and hepatotoxicity also there, but rare. So nephrotoxicity, acute infusion-related reactions, and hypopotasemia, hypomagnesemia, anemia, hepatic dysfunction. There are different formulations. One is conventional, then lipid complex, colloidal dispersion and liposomal embolism P. So lipid complex, ABLC. Here incorporating ribbon-like particles in phospholipids mainly. So it's like you can see here lipid and embolism B. Here it is colloidal dispersion, disc particles. So cholesterol structure embolism B incorporated. 50% of embolism B and cholesterol listed. Here liposome, so it's a unilamellar vesicles. You can see it's water soluble agent and fat soluble amputated. So that's how it there. So liposome. Lipid formulations are mild acute reactions compared to conventional deoxycholate variety. Can be used in intolerance to conventional preparations. Low nephrotoxicity and anemia. Deliver amphotericin B to reticular endothelial cells of liver and spleen. So usefulness in leishmania immunocompromised patients. Can be used in higher doses compared to conventional variety. So you can say it's a liposome. So it's lysosomal. This is the lysosome in macrophage. So it's engulf, phagocytosis, fusion, phagolysomal fusion, and release from macrophages. So it's like a Trojan horse. We'll discuss about nystatin bit. Similar to amphotericin B, high systemic toxicity, often used as topical as well as we often use for patient with Candida esophagitis. We often use. Natamycin, similar to nystatin, broad spectrum, used often topically as ointment. Cruciferin, it's with microtubular dysfunction. So fungistatin, often for superficial fungal infections, most again for dermatophytes. Action cruciferin interact with polymerized microtubules. So you can see here cruciferin leads to inhibition of mitosis by cruciferin. Oral administration is irregular absorption increased by fatty foods and microfine particles. Gets concentrated in keratinized tissues. So that's why it's more effective for dermatophytes. It's mainly metabolized in liver. So glycerolin also having interaction with cytochrome P50. Induction of cytochrome P50 activities is increased. Adverse events, mainly headache is the concern. Then GIT anomalies, CNS, transient leukopenia likewise. Often used systemic only for dermatophytosis. For the systemically, Sayazole are preferred by for the topical only dermatophytosis we often use. Duration of treatments usually 4 weeks, like depends. Okay. Another drug, flucytosine, purine inhibitor. It's a prodrug, pyrimidine analog, antimetabolite, converted to 5-fluorouracil. Human cells can't convert it to 5-fluorouracil. Adverse events, mainly it causes bone marrow toxicity, gastrointestinal toxicity, alopecia, skin rashes. It affects mainly rapidly growing cells. It often used for cryptococcal meningitis in patients with HIV as a combination with amphotericin B. It has a narrow spectrum of activity. So how it acts, you can see where it decreased DTMP leads to inhibition of DNA synthesis and cell division. Once combined, it's reduced toxicity, rapid culture conversion, reduced duration of therapy, having a synergism. Difference when we compare amphotericin is active drug, broad spectrum, while not Tapso, highly protein binding, no blood-brain barrier penetration. About azoles, it's a synthetic antifungals, broad spectrum, fungicidal or fungistatin. Most commonly used imidazole or triazoles. Imidazoles store nitrogen in structure. Topical econazole, miconazole, clotrimazole, cysteine ketoconazoles. There are novel oxyconazoles, sulconazoles like triazoles, three nitrogen in structure, fluconazole, itraconazole, voriconazole, isobuconazole, likewise osaconazole. Both these groups are structurally related, have same mechanism of action, have similar antifungal spectrum. So terminifene, which acts equally in 2,3 epoxide. So here it acts azoles 14 alpha demethylase. So it's inhibit the conversion of lanositol to ergostrol. There are topical uses. Miconazole 2%, cotrimazole 1%. So for the 2 weeks in pityriasis vesicle, 4 weeks in tinea cruris, capitis, and corporis. It's often used for dermatophyte infections. Adverse events, local irritation, itching, burning, like ketoconazole. It's a first orally effective broad spectrum antifungal, effective against dermatophytes, deep mycosis, and candidiasis. It inhibits lanesterol to ergostrol pathways conversion. When we consider pharmacokinetics, it's orally effective. Acidic environment favor absorption, high protein binding, readily distributed, but not in blood-brain barrier. Metabolized in liver, excreted in bile. Adverse events, nausea, vomiting, headache, steroid, testosterone, estrogen system synthesis is reduced, leads to gynecomastia, oligospermia, loss of libido, elevation of liver enzymes. So once we are given, we have to monitor the liver enzymes, HGO, PT, OT, and PT. Hypersensitive reactions, skin rashes, itching are possibilities. There are drug interactions. Often ketoconazole and amphotericin B are not combined. They are simultaneously not prescribed. And also it inhibits cytochrome P450. Here, amphotericin B induces. So often uses are dermatophytosis. It's concentrated in stratum corneum. Monilial vaginitis, systemic mycosis, we often give. Fluconazole, it's another novel water-soluble triazole. Oral IV as well as topical are available, broad spectrum activity, but it is not against aspergillus and mucormycosis. 90% oral bioavailability is there when consider pharmacokinetics, not affected by food or gastric pH compared to fluconazole. Sorry, ketoconazole. Sorry. Primarily excreted unchanged in urine, poor protein binding, widely distributed crosses blood-brain barrier. There are adverse effects like GIT upset, headache, teratogenic effect, So it also cytochrome P50 enzyme inhibiting property. No anti-androgenic and other endocrine effects like earlier. Often we use for Candida, candidiasis, oral candidiasis, tinea infection, systemic fungal infection including disseminated candidiasis, cryptococcosis, coccidial meningitis. So eye drops for fungal keratitis also available. Itraconazole, it's a broad spectrum, also having the activity against aspergillus. Fungistatic, does not inhibit steroid hormone synthesis and no serious hepatotoxicity. Usually 50 to 60% are bioavailable. Absorption is variable, enhanced by food and gastric acidity. High protein binding. Well distributed accumulates in vaginal mucosa, nails, but CNS penetration here also poor. Metabolized in liver. Uses. It's for paracoccidomycosis, chomoblastomycosis, for histoplasmosis, blastomycosis, esophageal and oropharyngeal vaginal, candidiasis, dermatosis, less effective than fluconazole. GI intolerance, hypokalemia, dizziness, drug interactions also there. So itraconazole and fluconazole comparison, you can just appreciate here. Voriconazole, novel variety. Second generation triazole. High oral bioavailability, low protein binding. It has a good CSF penetration. Doesn't require gastric acidity. Uses for the invasive aspergillus. So aspergillus, it's voriconazole. Okay. Usually 200 milligram. Adverse events, there are visual changes like blurring, altered color perception, photophobia documented. Also rashes, less percent 5 to 6, elevated hepatic enzymes, prolonged Q2. So we have to monitor liver enzymes and dose adjustment is required. Terbinafine, it's usually oral and topically effective, has a fungicidal activity. Oral absorption is good. Adverse events, nausea, vomiting, diarrhea, taste disturbance. It's also used for dermatosis and including nail infections, fungal onychomycosis, and candidiasis. Caspofungin, semi-synthetic antifungal, it inhibits beta-1,3-D-glucan, an essential integral component of fungal cell wall. Treatment of invasive aspergillosis and candidiasis. So associated flushing, rashes, nausea. There are different formulations. Are there anolidofungin, caspofungin? Those things are there. Topical agents for dermatosis. There are tolonafate, ciprofix, cycloprix, olamines. There are a lot. Sodium thiosulfate, benzoic acid. There are selenium sulfide we often use, potassium iodide. So there are, for the summary, systemic administration, glycyrrolline, ketoconazole. For the topical, ketoconazole, meconazole, cotrimazole, terbinafine, statin are there. And spectrum of action, you can say aspergillus, it's mainly traconazole and voriconazole, blastomycosis, cryptococcosis, how it acts, fly for flucytosine, likewise. Okay. Fluconazole, fusarium species, and amphotericin B. Spectrum of action, nystatin, glycyrrolline, terbinafine, caspofungin, aspergillosis, and candidiasis. For the broad spectrum, amphotericin, ketoconazole, fluconazole, itraconazole. This flucytosine is highly more prone to develop resistance. Nephrotoxicity anemia is related to amphotericin B. Likewise. Thank you.